Assalamualaikum and hi everyone. I'm Dr. Faiziah Rahman, breast and endocrine pathologist from University Science Malaysia, USM. USM located on the east coast of Malaysia at Kubang, Krian, Kota Baru, Kelantan. And USM Health Campus offers various health courses, including medical course. And this is Hospital USM Building, the tertiary center in Kelantan State that attached to USM Health Campus. You all are welcome. And I'm happy today to share breast cases from Malaysia experience. Majority of cases are my referral collection cases. Now we start with the case number 1. We have 38 Chinese female breast lump for 6 months associated with nipple discharge. Ultrasound shows sediment within cystic lesion and with that suggestive of chronic abscess with infected cyst. The Barrett score 2. Accessional biopsy done. All right, what we have is a state lesion with the cyst wall lined by this type of epithelium together with the cyst content. Many sampling done, including levels from fibrous capsule, and in some areas we found intraductal component, all right, within the fibrous capsule. And in other areas, the fibrous capsule appears thickened with an increased number of intraductal component. All right, and the higher power view of one of the intraductal lesion or component we found, it composed of apocrine cells with abundance pale to eosinophilic granular cytoplasm, and nuclear shows moderate atypia. And I think everyone agree with me that this is DCIS, low to intermediate grade, and it has a similar morphology in all intraductal component. All right. In other areas, we found scattered invasive component can also be seen within the fibrous capsule. The cells that lining the fibrous capsule also malignant looking, forming a micropapillary tuft. All right. A higher power view of the cells that lining the fibrous capsule, it composed a type A apocrine feature with marked dysplasia and a mitosis. This in another area, we found scattered mitosis with marked dysplasia of the cells. And further thorough sampling endeavors have been done, and in one area, at the area that we found the invasive component, we found from the levels show increasing in the size of the invasive component, but still within the fibrous capsule, not permeate beyond the bed capsule. All right. Okay. The cells within the invasive component is also apocrine cells with intermediate nuclei. And the cell's morphology depicted similar morphology with the cells that lining the fibrous capsule, and as well as the cells within the in situ component. All right. And then we proceed with the P63 and S100 that shows both negative, indicate lack of myoepithelium lining the fibrous capsule, but positive in normal ducts and DCIS. However, they are totally lost in invasive component. All right. HER2 shows positive with 3+ and ER/PR negative because of apocrine cells. And so what is diagnosis for the case number 1? What we have intraductal lesion with papillary architecture and apocrine changes. More than 90% of the cells show apocrine change, and with lack of myoepithelium at periphery of the lesion, DCIS and invasive foci present with similar morphology within the fibrous capsule, but not permeate beyond the fibrous capsule. All right. So the diagnosis of case number 1 is apocrine encapsulated papillary carcinoma, PTIS. Apocrine EPC is very rare variant of malignant papillary breast lesion, usually present with cystic mass and mural nodule. Also, can also present as central retroareolar mass with or without nipple discharge. Ultrasound may feature as complex cysts similar to abscess. And we need myoepithelium panels, CK56, P63, calponin, S100, and SMA to differentiate between papillary DCIS. And both lack myoepithelium within the papillary tree, but papillary DCIS positive at the periphery of the capsule. I just want to highlight some issues in apocrine cells in EPC. And for example, in this case, S100 usually more sensitive in apocrine cases. P63 can be also negative. Apocrine causes ER-PR negative, in which only positive for androgen receptor. We never rely solely on the absence of myoepithelial cell layer when classifying apocrine lesion. We need to do myoepithelial cell panels and evaluate other features, cytology, architecture, and also their underlying lesions. Apocrine cells always display cytological atypia and architectural complexity. Therefore, they require at least 3-4 variation nucleosides to say they are atypia. And therefore, to call high-grade apocrine DCIS require more complex feature. All right. The issues that are related to DCIS and invasive component in EPC. EPC with high nuclear grade or nuclear polymorphism and hyperptosis or triple negative or HER2 positive phenotype should be graded, staged, and managed as invasive carcinoma. This is stated within our recent breast pathology WHO. Then, should we manage this EPC in our case as invasive cancer? All right. So, regarding DCIS and invasive component with similar growth pattern, it's still within the fibrous capsule and which is not considered as frank invasion. Therefore, we still stage this lesion as PTIS. Okay. However, in this case, we put up a long comment where the presence of associated DCIS, invasive component within fibrous capsule, and HER2 positivity confer a higher risk of local recurrence. Therefore, complete surgical excision with extensive sampling of surrounding breast tissue is essential for treatment and assessment of local recurrent risk. All right. So now we move on to case number 2. We have 75 Malay female with palpable breast mass and bloody nipple discharge. The mammogram shows Barrett's 4 and core needle biopsy done. All right. So what we have is 2 strips of tissue, of tumor tissue with infiltrating tumor in solid pattern that intersperses with clear whitish foci. All right. And a closer view shows sheets of uniform tumor cells, in solid growth pattern, okay, with delicate fibrovascular core here and there, all right? Also presence of mucus, all right? And then if we can appreciate the cell that lining of this core showing the palisading nuclei, all right? Higher power view shows monotonous cells with low-grade nuclei, okay? Low-grade nuclei together with delicate fibrovascular core, all right? Delicate fibrovascular core. And there is a nuclear palisading around the fibrovascular core forming like a pseudo-rosette formation, all right? Okay. And in other areas, it shows a solid tumor, solid nodule, nodule with well-circumscribed contour, okay? If we look at the cells within this nodule, it looks like florid UDH with a heterogeneous type of cells, very low grade with a smooth outline here. And if, under higher power, what we can appreciate here, the cells shows around the spindle sheet cells. Sometimes maybe not obvious here. Yeah, in other area it showing like streaming like a pattern in UDH. All right. So in other areas, it exhibit extracellular mucin here, the mucin pool at the periphery of the lesion. Okay, the mucin pool. However, the scattered mucin are lack of floating cells, floating tumor cells, as what happened in mucinous carcinoma. All right. So we proceed this case with immunohistochemistry of synoptophasing, which showing strongly positive in all areas. ER and PR also strongly positive. However, HER2 a negative and CK56 also a negative. All right. So what is the diagnosis of this case? We have postmenopausal woman with breast lump and bloody nipple discharge, tumors with solid growth pattern, and inconspicuous delicate fibrovascular core, nodules rounded with smooth contour with myoepithelial cells absent. So I think this is very straightforward with the key features that we have seen one by one. This is fixed to call it solid papillary carcinoma. Or is it in situ or invasive or with invasion? Can we diagnose in biopsy? I don't think so, because it must be determined on excised tissue. All right. So there are some issues in SPC and biopsy. Can we diagnose SPC in biopsy sample? Can we determine in situ invasive or with invasion? All right. So I think all that must be determined in the excision sample. For this case, the excision shows invasive foci with the nodules with geographical jigsaw pattern with absence of myoepithelial cells, and it confirmed diagnosis of invasive solid papillary carcinoma PTIS and 0. All right. And then we move on to the next case. Case number 3, we have 70 Chinese female, known case of invasive breast carcinoma, first biopsy done more than 15 years ago, and patient then defaulted. Presented this time with large tumor involving the skin, neoadjuvant chemotherapy following toilet mastectomy done. And the reason of referral, whether is it neuroendocrine carcinoma, to rule out neuroendocrine carcinoma. All right. So what we have in this case is it shows multiple tumor nodules in solid growth patterns with irregular contour at periphery of the tumor. All right. Okay. Look at the stroma. It shows desmoplastic stromarection, and look at the nodules. They're showing the geographical jigsaw patterns with ragged contour. All right. And then closer view of the nodules. We can see here the cell showing the monotonous population of cells, low-grade nuclei with delicate fibrovascular core. Okay. And the cells are forming pseudorosette formation. Okay. And yeah, this is a fibrovascular core. It's a very delicate fibrovascular core with nuclear palisading surround this core. Okay. And we proceed this case with both synaptophysin and chromogranin A, and it shows strongly positive. ER/PR also positive, HER2 negative. So this is, I think, also straightforward, but this is an excision tissue. It shows a case of ER/PR strongly positive, HER2 negative, P63 negative in all nodules in this case. The postmenopausal woman, postmenopausal woman with indolent tumor which has been diagnosed more than 15 years ago with invasive tumor nodules in solid pattern and delicate fibrovascular core with ragged contour, occupying the whole tumor with desmoplastic stromal and the main tumor composed of expansile solid nodule from dilated duct, which is not included in the picture here, with neuroendocrine differentiation. So actually, this is a case of invasive solid papillary carcinoma, with that showing the neuroendocrine features of solid papillary carcinoma, not a neuroendocrine carcinoma. All right. Now we move on a clinical case of the last case number 4, with a clinical history of 59 Chinese female left breast lump for 3 months, painless, no nipple discharge, that gradual increase in size. The mammogram shows indeterminate nature with non-aggressive solid nodule, non-aggressive. Ultrasound shows ultrasound guided biopsy reported as invasive breast carcinoma. All right. The CT tab shows breast nodule, no obvious metastasis. And then they proceed with left mastectomy in this case. All right. Now, let's look at the biopsy. Okay. Let's look at the biopsy. This is a needle core biopsy. Under scanning view, it shows a cellular infiltrating tumor without areas of normal breast parenchyma here. All right. And and then the closer view of the tissue shows a solid tumor, and a solid tumor with high stroma with multicystic tubular lumens. You can see here the multicystic tubular lumens with secretion inside. All right, you can see the secretion inside. All right, and in other areas, we can appreciate here the thick hyalinized stroma with the normal ducts here. Okay. This view highlight the dense sclerotic stroma and also the cystic lumen with secretion here and there, and also the nuclei. Nuclei here shows low-grade nuclei. All right, and this to highlight the sclerotic collagenous stroma. Yeah, this is the secretion within the lumen, cystic lumen. Looking at the nuclear features, the cells actually are having the clear vacuolated to granular cytoplasm. However, there is no mitosis seen. Okay. Then we proceed with P63, which is totally negative in tumor cells with a nice control, internal control here. The ER, PR, HER2 all negative. All right, negative. But the biopsy diagnosis come out as invasive breast carcinoma grade 1 with triple negative. All right, when the carcinoma is grade 1 but triple negative, maybe we need to things. There are things to ponder about this. When we have low grade triple negative tumor, is it possible that these are atypical microcandular adenosis, or is it metaplastic carcinoma of low grade, or is it adenoid cystic carcinoma, or is it a secretory carcinoma? All right. Workout done in excision tissue, where mastectomy and axillary clearance done. The tumor is a retroareolar tumor with the size of 2 by 2 centimeter with well circumscribed lesion. It shows a solid cellular tumor with well encapsulated pushing tumor border. All right. So this is a fibrous capsule. This is a pushing tumor, and there are scattered sclerotic stroma, myxoid, and sclerotic stroma. All right. Yeah, this is a highly nice to myxoid stroma. Highly nice to myxoid stroma with scattered lumen and cysts present here. Okay. And look, looking at the nuclear features, we found that this is a low-grade nuclei with clear vacuolated cytoplasm, all right? And in some areas, it shows large number of cysts, all right, surrounded by the myxoid to highly nice stroma, all right? The cysts contain the secretion. Some of the secretion are thickened, eosinophilic, all right? And this to highlight the C's with the secretions. All right. And then we proceed with the past stain, and we found that both extracellular and intracellular secretions are positive for the past stain. And then we also proceed with the Austrian blue that showing the positive within the secretion. All right. And then S100 protein shows strongly positive. Okay, so the key features here, this is encapsulated and pushing. This is a tumor with encapsulated tumor which pushing tumor border. The tumor cells mainly in solid admits with microcystic tubular lumens containing the past Austrian blue positive secretion, and the tumor cells separated by highly nice stroma. And it shows a low-grade nuclei with clear to vacuolated cytoplasm, no microsis. The tumor is triple negative with S100 strongly positive. No axillary lymph node metastasis seen because the patient axillary clearance had been done in this patient. All right. So what is the best diagnosis for this case? And this is secretory carcinoma of the breast, grade 1. All right. Okay, maybe we really found that secretory carcinoma has numerous secretory components, like as what you see in this picture. Okay. We normally think of secretory carcinoma when we have abundance secretory components, and sometimes it looks like adenoid cystic carcinoma, like in this picture. All right, but the fact is it can be a solid with only single cyst. Predominant solid and tubular-like pattern may cause difficulty in giving a diagnosis. Therefore, S100 pass and Austrian blue stain is, I think, very helpful in this case. All right. So, thank you for your attention. Any inquiries, you can email me, and I'm happy to share more cases with you all. Again, okay, till we meet again. Assalamualaikum.